My name is Gary Painter, and among other things, I have the opportunity to direct the Homelessness Policy Research Institute, which we call HPRI as well, which is a partnership between the USC Price Center for Social Innovation and the United Way of Greater Los Angeles Home for Good initiative in some sense. But what it's really is a partnership among a bunch of careful researchers who come together to think about how we can best contribute to finding the ways to end chronic homelessness, which is why we're all here. That's why we have the Everyone's In campaign and so forth. And so before we get started, I'd like to go ahead, because of the partnership, to welcome my colleague Chris Kotish to say a few words.
Good morning, everybody. How are you? It's amazing to be in this space with you all, to more formally kind of do our work together, discuss our work together, which is the point of HPRI and everything that we do. Andrea was asking me about my dress today, and HPRI is also the place where I get to not wear a suit and tie, which I appreciate very deeply. But when the Conrad and Hilton Foundation and we and the funders collaborative were discussing the next step, the next set of tables, the next set of important stakeholders we need to make sure we partnered with in a more intentional way, I feel like researchers in the academy in that world was something that we knew for a long time we knew can make an even greater contribution to our work. We hadn't invited you all to the party in as intentional of a way. And we're so excited for you to have your skills, your work, your experiences really impact the work of the policy space in a more intentional and deeper way. And that is what this is about, right? So even the topic today, supportive housing, is something we have studied and proven and talked about, and has been such a critical part of our work in ending homelessness for the past 10 years. And what we're about to talk about today is how do we make that even better? How do we resource that even more deeply? What are some of the things that we can think more critically about? And that's what this is all about. And so I'm so proud and so glad for the partnership we have, like Gary said, not only with USC and this center, but with the wider academy. The other thing that we try to do in our work is bridge all divides, and so we're also very intentional in having Gary and his team, and Gary being gracious and excited to have UCLA as an associate director in this partnership, and so we try to heal all divides in that way as well. And not only UCLA, but I think other incredible research institutes and firms and think tanks in the world. We certainly need all of your thoughts and your questions, so thank you for jumping into this work with us. We look forward to everything ahead.
So it's my pleasure today to welcome you to the first HPRI Research Symposium. We, as Chris said, we know it's a critical space to bring researchers together with those who are embedded in policymaking organizations and research organizations to really think about what are those next questions that need to be answered, and to reflect on what have been the answers to date and what are the challenges that remain as we study things. And most of you know about HPRI, but just to kind of give you kind of 4 bullets on what we try to accomplish as a collection of researchers. What we try to do is, number 1, foster collaboration and coordination among our research community for people who are studying homelessness in the LA region, or for those who are outside the LA region who study homelessness in the LA region. So we have a lot of partners around the country who study this as well. We really want to translate those research findings to policymakers and community partners to inform the work to end chronic homelessness. We function to conduct rapid response research requests that we get from our public sector partners, from our community partners, from our providers, to get a sense of what's the state of best practices, what kind of information can we bring as we're deploying resources on as much of a real-time basis as possible. And we also work with our partners to help assist and develop research proposals and programs so that we can have the strongest kinds of evaluation, the strongest kinds of learning frameworks applied when we are deploying resources to end chronic homelessness. So those are really the 4 things. We're really pleased again to host this particular symposium, which is going to highlight a really important report from the National Academy of Sciences, which is titled Permanent Supportive Housing, Evaluating the Evidence for Improving Healthcare Outcomes Among People Experiencing Chronic Homelessness. I'm not going to ask who read the whole report. I'm a professor, so I know not to ask my students if you've read all of the reading for today's class. It is a long report. report, and it's intentionally long to make sure that they have covered the scope and depth of what you need to be able to say something consequential about particular issues. And today we're really excited to have HPRI's own Dr. Suzanne Wenzel, who contributed to this report. She's going to do a couple of things. She's going to provide kind of a presentation on the key research findings for those of you who haven't read the whole report. And then we're going to have a conversation where we're going to be talking about some of the policy implications, next steps, what are the kinds of research questions that remain unanswered that could be. And so we're going to move from podium to over there. I might tee up a question or two, but it's really intended to have a discussion around the kind of the questions that you have in mind, whether you're coming at it from a research perspective or whether you're coming at it from a policy perspective, so that we can kind of engage what are those next hypotheses that we need to test and have a better sense of as we go forward. So I'm going to tell you a little bit about our own Dr. Suzanne Wenzel. She's a research partner here at HPRI. She's a member of the steering committee of HPRI as well. Here at the USC Suzanne Dworak-Peck School of Social Work, she's the Richard and Ann Thor professor in urban social development. And she's, as many of you know, served as a principal investigator on numerous National Institutes of Health grant. Her research is quite broad, and her research specifically in terms of looking at homeless persons has investigated social context of risk for substance abuse and HIV/AIDS among homeless men, women, and youth, the examination of the relationship of trauma to substance abuse and HIV/AIDS risk among women, adaptation of evidence-based programs to assess HIV risk, victimization by violence, and post-traumatic stress among women, and many other things. So without more, I could go on. The vita is quite long and impressive, but let me just ask you to welcome me and welcoming Suzanne to the podium.
Well, thank you very much, everyone. I'm really honored to have this opportunity to share some sense of the findings from this National Academies of Sciences effort that was an 18-month effort that began in 2016. And I want to compliment Gary and the entire team in HPRI for what a wonderful and necessary service that they are providing, not only within USC, but within Los Angeles and abroad. So thanks to Gary and Megan and the entire team. So what I have done here, I just want to be completely transparent in stating that I received the PowerPoint slides that our chair, our committee chair at National Academies, used in presenting this complete set of findings during the webinar when the report was released in July in Washington, D.C. So Ken Kaiser was very kind to share the PowerPoint, and I've taken some liberties in editing them, reducing them, and focusing on what I thought, what Gary and others and I thought would be most important in terms of spurring a useful discussion today among all of you. Just a few preparatory or preface type comments regarding housing and health. This report and our work focused on permanent supportive housing, but we acknowledged as we set out to do this review and this work that there are many different kinds of housing interventions or interventions that are meant to assist persons experiencing homelessness. You know, way back in 1984, there was the McKinney Assistance Act, and the solution at that time was thought to be temporary shelter. Well, that clearly didn't work as a permanent means of addressing homelessness, but we recognize that there have been a number of efforts, and some of them do provide housing of one kind or another. And we were working specifically from the context of understanding permanent supportive housing and how it contributes to health outcomes for chronically homeless persons. And we have a definition, a working definition of permanent supportive housing that I think is consistent with expectations, that it is housing that combines, it's a service that combines housing that is not time limited. It could be permanent for a given individual depending on his or her needs. It's combined with supportive services that are voluntary and tailored to the person's particular needs. And there is absolutely no doubt that homelessness is horrific for people's health. So we start with that at the outset. There was an Institute of Medicine report in 1988 on homelessness, health, and human needs that reviewed all of the evidence and demonstrated incontrovertibly that homelessness is horrible for people's health in every possible way. and some of the ways in which homelessness is horrible for people's health. You know, it can exacerbate existing problems, but it can also cause new problems to occur. So persons experiencing homelessness have higher risk for many kinds of diseases, afflictions, infectious diseases certainly. There's also greater risk of experiencing serious traumatic injuries. And for women in particular, that is higher rates of sexual assault. There are, you know, the conditions related to homelessness and sleeping on the streets are, you know, profoundly challenging. I really don't need to talk about that in depth because we all understand it. And there's also the matter that health care services, when they are utilized by persons experiencing homelessness, may not necessarily be utilized in a way that is the best use of public health care systems. They are more likely very often to visit emergency rooms, and when that is not medically necessary care. So based on that foundation, there are compelling reasons to better understand whether the interventions that have been shown to reduce homelessness, and yes, permanent supportive housing reduces homelessness, there is absolutely no question. It's also reasonable to ask whether those interventions can also reduce the adverse health consequences of experiencing homelessness. Does permanent supportive housing improve health outcomes for persons who are in permanent supportive housing? And that was our primary research question. We had a bunch of questions that we were charged to address by our supporters, but this was the principal one. To what extent has permanent supportive housing improved health outcomes and affected healthcare costs for persons experiencing homelessness? So let's just start with some overarching conclusions first of all. And yes, indeed, just as I had said, permanent supportive housing is absolutely effective in keeping persons safely and stably housed. And so there's great potential for reducing, you know, the numbers of persons experiencing chronic homelessness, but also for improving their health outcomes. So why not look at this carefully? And ultimately, the committee was somewhat disappointed that the findings for permanent supportive housing's effect on health outcomes wasn't stronger. But there's a very strong platform of information to build upon. And fundamentally, permanent supportive housing needs to be expanded because, as we know, there continues to be substantial unmet need for that service of permanent supportive housing. So whether we can definitively conclude that permanent supportive housing improves health outcomes or not, we know permanent supportive housing helps to reduce homelessness. So we need to expand our capacity to do that and be very careful about our future studies in understanding health outcomes. So what we faced in going through very systematically lots and lots and lots of literature is that there have actually been few very well-designed studies that demonstrate effectiveness of permanent supportive housing in improving health outcomes. And by high-quality research, well, that was the National Academies of Sciences, Engineering, and Medicine, so there is a high bar. We want to be sure that when we are trying to make claims about causality, that we have the methodology to support it. And so one of the highest standards is the randomized controlled trial, or very strong quasi-experimental designs. And there were very few such studies that could provide that kind of definitive evidence. So that's, that was a limitation. We have an evidentiary base, therefore, that's somewhat incomplete. There's still a lot of inconsistencies in how people are defining permanent supportive housing. Inconsistencies in the level of services provided. Health outcomes data have not been the best. Sometimes we focused more on services rather than people's individual health outcomes, whether biological or self-reported. So the research data has just been too limited thus far. But the bright light, as you see in the final bullet point in this slide, is that, the bright exception is that persons living with HIV/AIDS in HPRI housing, for example, that is where we see that there has been a benefit to health outcomes. CD4 counts change, viral load changes. For persons living with HIV/AIDS, in housing design for persons with HIV/AIDS, supportive housing, we do see that housing affects health outcomes. So we know it's probably out there. We just haven't quite been able to see it yet. So now I pulled out some recommendations from the report, and I made up one or two because I think they're important, and I'm sure I'll be forgiven for that. but you won't know the difference maybe. I didn't mark them. I was going to do it, but I thought, I won't do it, so sorry. So one of the reports, well, this is a recommendation that was put forth by the committee, and that is perhaps we should pay more attention to exploring those conditions, those health conditions which are sensitive to the potential impact of housing. As stated, there are persons who are experiencing homelessness who have particular health conditions for which the failure to provide housing we would expect would result in significant worsening of their health. And we're referring to those as housing-sensitive conditions. So this is not to say that the committee doesn't think that housing is good for health, but if we want to demonstrate it, then perhaps we need to look at those health conditions that could be most impacted. So I think in the medical field, there is reference to acute housing-sensitive conditions and preventative conditions. So an acute condition might be somebody who is experiencing severe wounds, perhaps from congestive heart failure. You know, there are very complicated wound care needs, or perhaps people need to store medication in a refrigerated place, and you can't do that on the street when you're homeless, or complicated regimens for medication. Perhaps one is experiencing cancer and has a complicated chemotherapy regimen, or perhaps there are side effects. So those are acute conditions that could very well be, and I couldn't imagine they wouldn't be, housing sensitive. And then there are preventative needs. One would be to keep, if you have pre-diabetes, you really need a place to be able to prepare your own food or to have better access to food. Perhaps you need an opportunity to prepare fresh vegetables or to eat fresh vegetables, and it's just harder to access that kind of thing, perhaps on the street. So housing sensitive conditions are something that we should examine. Not to say that housing is not good for health, but let's start focusing perhaps on those conditions that might be more amenable to change and could be prevented from worsening in a protected environment. And this particular recommendation with the complicated title, Harmonizing Permanent Supportive Housing Definitions and Defining Program Characteristics and Services, I kind of mashed together a couple of recommendations, and they are at the program level. So I've already mentioned that there is some diversity, there is some variety in the models of permanent supportive housing. And it's not only in terms of how they're officially defined, but it's also in how they are implemented. The level of fidelity with which permanent supportive housing is implemented. The models vary, for example, in terms of whether they are scattered site or single site. And those kinds of characteristics could be associated with different outcomes. But systematic understanding of that does not yet exist. And when we have looked at even well-conducted randomized control trials like the Chez-Soi study in Canada, which is probably one of the very best, we see that the information on the services that each person receives as part of the permanent housing have not been well described in terms of types of services, the range, the intensity, the duration. And in a randomized control trial, we compare our treatment, in this case permanent supportive housing, to quote-unquote usual services very often. And there's also been no understanding of, well, what are those usual services that people are getting? So we have to understand the process. So those of you who do evaluation work, there are process evaluations and there are outcomes evaluations. Well, we need to spend more attention and time on understanding processes in permanent supportive housing, particularly when we're comparing usual services to permanent supportive housing and how people do. Does that make sense? So we have to understand the mechanisms and the processes in order to understand the outcomes. So what we're recommending is, specification and further delineation of the characteristics of the supportive services. the characteristics, what kinds of services, but also the kind of housing or the model. And we posed a question about whether it would make sense to define some minimum standard. You know, as far as we know, there is no minimum standard of services that should be provided in permanent supportive housing. And maybe that's because we know that services should be tailored to each person's need. But if it were possible to determine whether people received some minimum, at least we would have a benchmark for comparison. So I'm asking for standardization, perhaps in a situation where standardization is the hardest to achieve. But it would further our efforts to try to understand how effective permanent supportive housing is in affecting health outcomes. And costs. We're not going to talk about costs today, but I do want to mention cost effectiveness really hasn't been looked at in this context. We haven't tried to look at cost per quality adjusted life year, or even cost per cost per quality adjusted life year is probably the best unit for understanding an impact in terms of cost effectiveness in permanent supportive housing. But there have been no cost effectiveness studies. And I also want to point out that the committee would not expect that costs would be reduced across the board by providing permanent supportive housing. We think it's unreasonable to be held to a standard that providing people permanent supportive housing will reduce costs, except perhaps in the case of averting unnecessary emergency care services. And that's sort of a fundamental principle that we adhere to, that we shouldn't be held to the standard that it should be cheaper to provide persons with a high level of need with services than allowing them to be homeless. We don't want to be held to that standard. But we should understand something about cost effectiveness, and we don't yet. At the individual level, we still have a lot more to understand regarding the characteristics of the individuals in permanent supportive housing. And one way we understand that is through our screening tools and our assessment tools, the measures that we use to understand the characteristics of persons who are entering permanent supportive housing and who are living in permanent supportive housing. And sometimes we have been using these tools that we've all worked very hard to create and very hard to implement to understand who might benefit the most from permanent supportive housing, or to try to predict health outcomes within permanent supportive housing. And with deep recognition and respect for all of our efforts in that regard, there's a lot we could do to enhance the measures thus far. I think they need a little more study to make them even better. There isn't a lot of support right now. We're not doing a really good job in being able to predict who is going to benefit the most from housing with the tools we have now. That doesn't mean we should stop using them. That means that we should gather more information to try to make them better, to make them more valid. And I know that's very complicated, but we would like to determine who could make the greatest use, who could benefit the most from permanent supportive housing. It's an important question, but there's still more work to do about that. So what we're recommending is further development and enhancement of these screening and assessment tools. And we might build this around the notion of housing-sensitive conditions. Maybe that would be fruitful. And there's one piece. Well, this is one of the recommendations that I added as a formal recommendation. I'm just going to say it. And we talked about this in the Research Gaps chapter, but this is critical. There just hasn't, part of the reason it's not in the report very much is because there's not been a lot of research, but we really need to do a better job in terms of understanding diversity in cultural, racial, ethnic, gender, sexual orientation, and services and outcomes. So that's been one area that we haven't looked at in terms of trying to understand who could benefit or who would need more services. Are issues regarding this. It could be the case, why wouldn't it be the case that in permanent supportive housing, just as in the healthcare system overall, there are stigmas. There might be stigmas on the part of providers. There could be challenges in terms of patient-doctor communication that emerge from implicit biases, that could emerge from a number of sources we just don't yet understand. So this is an area that we need to understand within permanent supportive housing as well. And to the extent we understand individual characteristics writ large, then we can better understand, those become effect modifiers, so to speak, in our models to try to understanding whether health outcomes change. Maybe they change based on individual characteristics that we haven't explored. Final recommendation, what we're continually struggling with, this fits into the overall section on scaling up permanent supportive housing, this issue of NIMBY. And it's certainly the case that there are regulatory challenges. There are challenges in very separate siloed funding streams, where you have housing coming ultimately from the Department of Housing and Urban Development. You have services dollars coming from Department of Health and Human Services. It's really hard to do the Medicaid waiver. It's very difficult to achieve Medicaid funding for housing-related services through a waiver. That can be just really tough to do. It's very complicated. So there are all kinds of barriers to scale up. And one of those that I think remains one of the last frontiers is this issue of the community-based resistance. And this must be overcome, because whether or not we can now show that health outcomes change, very definitively, we know that permanent supportive housing ends homelessness. And we've got to address this somehow to be able to move forward and make sure that people understand that persons who've experienced homelessness are our neighbors and they're our brothers and sisters, and they deserve to live among us as members of the community. So, concluding thoughts. I'll just read this. Addressing chronic homelessness requires a multidimensional strategy and an ample menu of targeted interventions premised on a resolute commitment of resources. I send this out to all of the funders and to the federal government and the state government if they will listen. And of course, we hope that this will further the well-being of persons experiencing homelessness and will stimulate research and action on their behalf. Briefly, these are the folks that served on the expert panel, 11 persons, including myself, from various universities and institutes across the country, and our study sponsors. So thank you so much for your attention.
I like to get into the research findings themselves a little bit and kind of uncover maybe why there is this lack of evidence. And I wondered if part of it, as you reviewed all of the papers, were because the particular research designs, whether quasi-experimental or experimental, were not focused on health outcomes per se as the main outcome, but they were ancillary, and therefore it was kind of hard to assemble that evidence, or if there was some other reason why you felt like we didn't learn enough in the current studies.
I think it was all of those.
Okay.
I think it was a combination of different factors. And first of all, we have to acknowledge how enormously difficult it is to design and launch and correctly implement a randomized control trial in this context. And there are issues that make it quite challenging beyond the technical ones. There's also, there are ethical concerns as well sometimes. So part of it is just that, and just not being able to conduct an RCT or a very strong quasi-experimental study like propensity scoring, using propensity scoring methods or regression discontinuity that would allow you to say that you have isolated all other potential explanations of health outcome change, and you can attribute it only and clearly to permanent supportive housing. Sometimes it's that, and sometimes, as we found, it's the case that service utilization has been more of a focus than health outcomes themselves. And there are two ways that we can further measure health outcomes. They're in terms of patient-reported experiences. Those are very important, but also in terms of CD4 counts, viral suppression in the case of HIV/AIDS, or I'm blanking on the measure of diabetes, the blood level. Is it A4? A1C, that's it. A1C levels in the case of a person with diabetes or hypertension. So those, for whatever reason, have just not received as much attention.
So the issue you brought up that were not necessarily in the report in terms of this, you could think about it in a rubric of subpopulations of various kinds.
Right.
where do you feel like at least the, top 2 or 3 places we might want to go in terms of studying subpopulations, rather than just kind of a generic people who are homeless, but to really look at particular kinds of groups who might be experiencing particular kinds of health conditions would be especially fruitful for research?
Well, if we think about individual characteristics, in terms of health conditions, I think that persons who are pre-diabetes or who are dealing with diabetes, that's quite a prevalent health condition at this point in this population. I think that would be very fruitful. Persons who are experiencing congestive heart failure, perhaps, because those kinds of symptoms can be probably better managed when housed than when homeless. Those kinds of conditions. But I also want to bring us back to an important individual characteristic that hasn't received attention. And this stems from the fact that there's very disproportionate, African Americans are disproportionately likely to experience homelessness. It's a very small percentage, for example, in Los Angeles County, who are African American. Maybe 10% of persons in Los Angeles County are African American, yet they make up the majority of persons experiencing homelessness. And so that reflects a legacy of racism, discrimination, and injustice. And I think we have not done enough to try to understand how persons of different cultural backgrounds or different races are experiencing permanent supportive housing, and whether the biases that we've seen in healthcare generally might also be occurring or not occurring in permanent supportive housing. So I think that is a critical and important focus, given that we're in looking at permanent supportive housing, we're acknowledging the social determinants of health, and we want to address health equity. So we have to have that as part of our portfolio.
Well, I have a few more, but I want to make sure that you get your questions in. Yes.
I have a couple of comments. One, my name is Miguel Fernandez. I'm the PSH coordinator for the Los Angeles Homeless Services Authority. And a couple of things I want to point out is that you really have to take into consideration how permanent supportive housing is being allocated to individuals based upon their needs. So clearly those that are going into permanent supportive housing are going to be the highest need individuals, co-occurring disorders. On top of that, we are implementing a low barrier, trauma-informed services are optional, it's your choice. It's housing first model. So many individuals that will go into permanent housing may choose not to receive these medical care services. Historically, from the homeless services continuum, it's been the priority is housing, keeping them housed. Yes. I've worked with the HIV community for the last 18 years, and your comment on the medical outcomes for HIV are so different, and it's because the focus is very different. We drilled it into our staff that diagnosis forms every year, look at the viral load, what's going on, what are you doing? Coming into the homeless continuum, I don't see that same mentality. It's when we asked about health outcomes, there's, oh, well, they said they report they're going to doctors. Okay, well, what's the outcome of that doctor's appointment? These kind of additional training that needs to take place in the homeless continuum to understand that you're not just providing the services and the referrals, but rather following up and knowing diabetes and what is how do you measure diabetes progression, or how do you measure the health outcomes and document that is something that providers still need. But then on top of that, you have the issue of resources. Do they have the resources to be able to have low enough caseload, get the training that they need to develop these skills to ask these types of questions? So it's a very deep series of issues, social, structural, and social agency-wise, that take into effectively health outcomes. My question is actually related to the staff itself, and understanding what are the characteristics of the staff to allow, or the agency itself to allow for outcomes. So one of the biggest focus that we're looking at right now is how do we systemize and train our staff to be able to ask those tough questions, to engage in stages of change, to engage motivation review. And so oftentimes providers will say, we do this, but when you ask for documentation that you're doing it with the client, they can't document it. And so there's a problem with that, is that we provide it, but we don't know how to do it. And so there's that aspect to that.
Well, first of all, let me thank you very much for providing more context surrounding these findings and for raising the issue that, I think we all have to acknowledge how challenging it is to be in the business of providing permanent supportive housing and being a case manager who is responsible for ensuring a person can live a more fulfilled life, a healthier life, and to retain his or her housing. So we've found in some of our research as well, some of it's reported in the flyer on your table, that case managers are really spending lots of time on ensuring a person remains housed. And that's what they're supposed to do. They're also supposed to connect that person to services, but how can you handle so much when you have a caseload that's enormous? I know that's becoming better, but those are very real concerns. Regarding your question about, what the providers implement, what the staff implement on a day-to-day basis to track, that has to be considered in the context of stretched resources. But I think it falls into the category of assessment and screening. So I think that's part of how we improve our assessment, is focusing not only on the measures themselves, but also giving support to and training to the persons who are responsible for administering those tools. That could be part of it. Thank you.
I'm Nicole Powell, supervisor with the Thomas's office. So in the introduction of your study, you highlight the need to focus on population health factors versus access to health care. So I was wondering if freedom from police brutality would be considered as a component of population health, particularly for unsheltered homeless folks who are consistently engaging with police or oftentimes profiled, and particularly given the disparities that you highlighted earlier.
Well, I certainly believe that, and I would say that the committee members would probably be in agreement. We were trying to stay on a particular, in some ways it felt like a narrow path of demonstrating health outcomes of permanent supportive housing, and we had sort of a context that we had to follow. But this is part of understanding the social determinants of health. And it also must be said that, engaging law enforcement engagement with persons experiencing homelessness may not be the best use of our public dollars. Whether it results in harassment and brutality or not, to the extent that we can better train or continue to train our law enforcement officials, and even better than that, perhaps, training outreach workers and case managers to extend warm hands of welcome that then transition into permanent safe housing. That's all the better. But I do want to acknowledge that comment and point out its importance. And I want to add to that as well, something I forgot to mention is that when we looked at the issue of health, just consistent with the importance of population health and context, we didn't limit ourselves to the way in which the medical system in the United States has typically viewed health over the last decades, but rather we use the World Health Organization definition of health. And that is that in general, health is not simply an absence of disease, but it's also a sense of well-being. And let me then highlight one finding that I didn't mention. And one of the health-related findings that we did see change in terms of self-report was this issue of well-being. So where quality of life and satisfaction has been measured over time among persons in permanent supportive housing, that does tend to improve. So that's very important to mention. So we know we're doing something right. And it's very important that people are feeling better about their lives, because that ultimately is something they deserve.
Thank you. Thank you, guys. My name is Jacqueline Johnson, and I am with Alexandria House, which is a shelter for homeless women who are also victims of domestic violence. And my concern is that not only is the NIMBY about not being in my backyard in effect, because we're trying to provide that kind of shelter, and we've been in Los Angeles, Koreatown for the last 22 years providing services. So my question would be, how are women, especially with families affected by the homelessness? Because I'm finding that not only are they minorities, African Americans and blacks and everything else, but when there is an opportunity to receive a voucher or Section 8 or help, that the same requirements of somebody credit check is applied. And if somebody's in a situation where you're being abused and hurt, I don't think you're going to take the time to clean the place, get your deposit back, and have a good rating. So the part of my question would be, how can research or studies help to maybe make it a little easier for people who are in need be able to not go through the same resolution of, well, you don't have a good credit score. So.
I think that those are critical questions and critical observations. You raised the question about how women experience homelessness, how it might differ from men. I might have mentioned that sexual assault is much more likely among women who are experiencing homelessness. There are a lot of, I've done research on this for a number of years and have spent time qualitative interviewing and just talking with women where they're living on the streets. And that is one of the things that it just so completely breaks my heart, that women might choose, for example, to have a partner who is not good for them as a way of protection against others who might assault them. So it's very complicated. And I know that there is further attention to trauma-informed care. Downtown Women's Center, for example, has been leading the charge in terms of building in trauma-informed care with their services. I know a lot of providers are engaged with that. These issues about how discrimination may occur in being eligible for housing based on the condition you had to leave a place because you were being pursued by an attacker. I don't know if that's being addressed, but I know that legal aid and legal services are a critical part of the package, or should be a critical part of the package of services in permanent supportive housing. Maybe others could more directly respond to her concern.
I mean, I think without directly responding, I mean, it just gets back to this question of understanding what vulnerability is and understand the different facets, right? So this is uncovering something that isn't necessarily talked about as deeply and is relevant for moving to a stably housed condition. And so that could be one of those things that we do think about, to document as we go forward, to understand, again, these elements of vulnerability that aren't being shown the light.
It could be part of the assessment, again, that this should be documented, and then this information should be taken to a level where it can be addressed. And it's also part of the NIMBY, because that NIMBY happens among the developers, among the managers who determine where a housing voucher can be used.
Yeah, thank you. I think the recommendation you have around parsing supportive housing is such an important one. So I guess I'm curious, were there any early kind of burgeoning findings already through crosstabs on this study that you saw between site-based and scattered site, or between certain programmatic outcomes, that you already are seeing some distinction in? And if not, I guess I also wonder for the room, since we have a lot of practitioners in the room, if you all in your programs have seen a distinction between health outcomes and site-based, scattered site, and service intensives.
There were some studies that tried to understand differences between scattered site and single site. And all I can remember off the top of my head in terms of the findings are that scattered site generally was more preferred. But I see one of my colleagues in the audience who might be able to address this. If Ben Henwood doesn't mind being picked on, I thought perhaps you could speak to this particular finding in the literature.
I'm Ben Henwood from USC. I was just saying that I don't think they looked at a lot in terms of health outcomes and differences. There are lots of other outcomes in terms of social support that are often looked at. But again, those studies tend to be pretty weak too in terms of not taking into account like neighborhood context and other factors that might kind of supersede the model itself. So I don't think we really know, to be honest.
Is there at least in service levels? Because I know in the portfolio mix, like part of what Measure H has been so critical for is increasing the floor of staff ratios with the intensive case management support. So I'm curious in people's programs whether you've seen that make a difference, if it's not scattered site versus second.
Yeah, I was thinking one complication of such a study is that, particularly here in Los Angeles, the folks that are on the ground doing the work, there's a sense that if somebody's tenancy is a little shaky, that the best thing to do is to connect them to a project-based site. And in a very informal way, we tend to funnel the folks that are the hardest of the hardest to keep housed to our project-based providers as opposed to our scattered site. So I think that digging down on that nuance between who's going to scattered site and project-based can be pretty tricky, and so the results that we get might not be telling the full story.
Joe?
Question? I'm happy to pass on the mic. So, I'm Thor from I'm a professor of economics at UCLA and head of the California Policy Lab, and we co-lead the HPRI, and so actually I'm very thankful to Kara and Susan because it's a great demonstration of what HPRI is there for, to think through these sort of broad research questions. And one question I had, and I want to put you in the spot, Susan, but somehow the report makes a strong case for additional hard evidence on some of these questions, and it seems to be that there could be a case made for some randomization on some of these issues. Because before I came here today, I would have said permanent supportive housing services are so important and so vital to so many people, it seems ethically inappropriate to randomize, but there seem to be some aspects here where there are really important open questions. And as we're as a research community thinking and having conversations with providers and so on, what are the sort of the key questions where we could think of doing an RCT that we should be thinking about? And so we're thinking of Santa Clara as running RCTs, for example, on permanent supportive housing, where the people that are most acute all get permanent supportive housing. And then there's a middle group based on the ISPDAT score where randomization takes place. And that would be one way to do this. But there might be many other ways to do this. And I was just curious what as you were writing the report, whether there were certain things in the back of your head that said, oh, here's actually a low-hanging fruit that where we could really make a lot of mileage if we were all to pull together and get the funding that providers support.
Well, I think, first of all, it's important to acknowledge that one of the key characteristics of a randomized control trial is giving every individual in the study an equal opportunity to be in either the control group, that is usual services, or the treatment group. So to put all of the highest need persons in one group and compare them to some other probably hurts your chances of finding an impact of permanent supportive housing because all of the high need people are in the treatment group. So if that makes sense. So what you really...
Just to clarify, that was a confusion. What I think Santa Clara is doing is randomizing within the middle acute folks.
Oh, I see.
Not, of course, not randomizing across acuity scores, but within acuity scores.
I see.
In fact, it's stratified so that within a range, right, you could even look at whether the treatment effect differs by acuity score.
Got it.
And all I just noticed is they assign everybody to a very high acuity permanent support housing, so nobody's randomized out with that very high acuity. So they're speaking to that potential trade-off you may face.
Right. If it were the case, however, that not everyone with the highest needs, based on maybe a comorbidity score, could be given permanent supportive housing immediately, if some people were inevitably placed on a wait list or in bridge housing for a period of time, then randomization would be an equitable way to allocate that precious resource of permanent supportive housing to a high acuity sample. Because eventually the people in the control group would get it as well. It's just that they happen to have been temporarily allocated or randomized to the non-permanent supportive housing group. I think I can understand the challenges that Santa Clara is facing, but to not randomize or examine the persons with the highest levels of need may contribute to some of the challenges that we saw in the report. So, I mean, ideally, we would be able to understand the effect of permanent supportive housing for the persons in the highest need groups, whatever that means based on our assessment tools, maybe a mid-range, maybe another. But the importance is demonstrating an effect for everyone who is now getting it, so we can better understand who may most need it. So, and the only way we can do that is through a technique that will equate people across, the people must be equated in terms of characteristics that could determine their health outcomes. So the people in usual services and the people in permanent supportive housing must look alike in every respect, except for the fact that one's getting permanent supportive housing and one is not. And then you can say that permanent supportive housing caused health outcomes to change. Unless you can do that, or unless you can use a good quasi-experimental strategy, regression discontinuity, propensity scores, synthetic controls, then it's really hard to demonstrate that effect. And remember that national academies use this very high standard because that high standard can quite convincingly tell us where the truth lies.
I think that's an important point about timing. Can be the way that we randomize as well.
I thought you meant timing as
no, sorry.
Are you out of time already?
You know, if you have a waiting list anyway, it's just a matter of everyone gets it, but not everyone gets it immediately in any circumstance.
Exactly.
Right? And so it's a way to kind of provide a learning framework so that the way that people get it doesn't actually compromise our ability to learn.
Exactly.
In a way that is, you know, kind of these notions of fairness and so forth are complicated.
And what better way to address or to allocate a precious, rare resource than by chance? So you're not saying, well, you know, you've been really nice today, or you look more deserving, so we're going to put you in permanent supportive housing. You know, what better way to do it than by flipping a coin, say?
Just because it's really interesting, and I think it's something we should continue to consider. I mean, hi everyone. I'm Andrea Lillian with the Commonwealth Foundation. I think there's a lot, as we've talked about a lot, there's a lot in this paper, and particularly, it sounds like there are even some really interesting policy questions or items for us to discuss. This is more of a research, you know, how do we move forward in the research locally? I will share that last week we were with the team from Santa Clara County, and they expressed discomfort and frustration about the fact that they felt they were re-traumatizing people by doing the RCTE. And it's been difficult for them in that community. And so it's just something to consider, like how clever group of researchers in here, how important you know, to what degree, how important is it? Are there certain programs where it might make more sense than others for certain reasons? But there is definitely, it was interesting, but also really difficult to hear from Santa Clara about the way that the RCT has impacted their engagement with the community and the way that some of their clients are feeling about it.
Thank you for raising that. It is very difficult sometimes.
I'm Dan Fleming from the Economic Roundtable. My comment is similar to Till's, that as I understand your population, it's middle-aged people and older, many of them with chronic health conditions, and so the standard might not be that they get better, but that they wouldn't get worse as quickly as their counterparts who are unhoused. And so there is certainly a large population with data, and these comparisons could be made certainly using propensity score matches, not as good as a random assignment, but still pretty good. And the second thought about this is that, as I understand, you found a reduction in use of emergency services. And that's a big deal for public costs, so that's not trivial at all that happened.
Yes, we did come across studies, I think are quite well known, that we can reduce emergency hospitalizations by housing persons, and that does result in a cost reduction. That's one very clear finding.
Hi, Jessica Monhecory at Corporation for Supportive Housing.
I know you mentioned some physical health conditions that you thought might be sensitive to housing. Was there any conclusions about mental health conditions and examining those and their changes with regards to housing?
Often when I'm thinking back to conditions that are either created by homelessness or worsened by homelessness, we might think that experiencing serious mental illness could be worsened, but not that homelessness would cause one to have schizophrenia. So certainly depressive symptoms would be a logical place to look in terms of changing mental health, but there are many others as well. So we're focusing, it depends on how we're measuring this. If we're talking about reducing severity in a serious mental illness as indicated by a constellation of symptoms, I think that is a very important place to look, yes. But we also have to remember that it's rarely the case, typically, that one condition occurs in isolation. So it might be a chronic health condition coupled with depression or anxiety or post-traumatic stress. And that's important to consider, not only how individual conditions change, but how different combinations of conditions or typical cases change.
So, Michael Nealot with United Way Greater Los Angeles. One of the things that we worked on a couple years ago was the Standards of Excellence. Chris was working on it and handed it off to me. But within that was a component of how do we set standards for how we should do supportive housing, right? And that was based upon a lot of feedback from people in the field, practitioners, housing developers, et cetera. And I was looking at it again, it's like 4 years old at this point. And there's really not a lot, obviously, on in terms of like quality of services, consistency, specifically around kind of like healthcare access and things like that. And so I'm wondering if there's enough yet, or maybe, you know, a recommendation is to figure out how can we start kind of developing some standardization around that. Like, is there a minimum standard of care that we should expect around access to health services and supportive housing? And are there any like real metrics that we can start tracking too? Because I know that you have this report to kind of give us a general sense of like what we know and what we don't know. But is there a way that we can kind of more actively kind of understand that as we start rolling out more supportive housing in the community?
Well, that's absolutely key. I mean, that's the heart of one of the recommendations, you know, to try to determine whether we can establish some minimum standards, including for quality, and then the assessment. So that's absolutely critical. So the committee will be, you know, overjoyed to know that there's work going on in that area.
Brenda Wewell, the director of the USC Initiative on Homelessness, and first I would like to thank Suzanne and Gary and HPRI. I'm really immensely proud of what's happening here. It's exciting to see that there's a blueprint that could actually guide us in making the decisions we want in terms of where we're going to focus our studies and what kinds of things we need to include and where some of the priorities are. So I'm really, really proud of that and happy to see that. And that's one of the reasons actually that we co-sponsored this. So we paid for your food today, so enjoy. And I actually was interested in the mental health as well, and the combination of mental health and substance use, which is also often present. And I actually wondered, was there any initial sense, somebody asked about that with the health conditions in terms of mental health or co-occurring disorders, that started to look at some of the impact and the outcomes in relation to the co-occurring condition?
So a number of studies, whether RCTs or not, have looked at changes in mental health conditions or changes in mental health symptoms and substance use over time in permanent supportive housing relative to usual services. And either change has not been detected. I mean, that's typically the issue, that there is not, there are not clear findings showing that mental health conditions and substance use changes over time. And where there is evidence, that tends not to be in the most rigorous studies. So it could be a longitudinal observational study, such as the one we conducted, Transitions to Housing in Los Angeles, that's sitting on your table, where we didn't have a comparison group. And so we saw some within-person changes over time in various areas, but that is not in comparison to a group. So we can't say that permanent supportive housing produced those changes, if that helps. So that it's not clear. It's just not clear that permanent supportive housing affects substance use and mental health severity.
Yeah, hi, Ben Henwood again from USC. I just wanted to make the comment that, you know, permanent supportive housing really targets people who are pretty sick already, just echoing some of the points already made. And you know, so if you have chronic conditions, it's pretty hard. I mean, healthcare systems really struggle to move the needle with this, you know, across the board. So there's part of me that's, you know, is it fair to expect that this intervention would, in and of itself, improve health outcomes? And I think there's been a lot of work done that, like, you really have to target the conditions that you want. I mean, there's been work done on depression and diabetes, and hoping that if you address diabetes, it'll somehow improve, or address depression will somehow improve diabetes, and they found that not to be true. And so really that's how the chronic care model came out, that you need to really think about these more broadly. So I think, you know, I really like the idea that there are housing sensitive conditions, but this kind of goes back to, you know, what are we designing this for? And I think if we're really serious about addressing health outcomes, then you would have, you know, health services as part of the supportive services more explicitly, in order to move the needle on it. And so I think, you know, the question of whether these programs think they're doing that, and if you were designing a program to do that, what those services would look like, is a really important question.
And the services issue is key. And I think one point that I forgot to make is that, you know, there have been no studies that have sort of tried to disentangle or separate the impact of housing itself from the services provided. And that's impossible in some respects because of the nature of permanent supportive housing. But it is possible to try to determine what services are provided and whether they are high quality services and what they're geared towards. So services are a key. And if we're trying to reduce depression, if that's the housing sensitive condition, then we need not only appropriate services, but we also need appropriate measures to follow that, to track that.
So we have time for a couple of more questions, and at the end I want to go for just a rapid kind of what is your hypothesis in this space that you have, either in your work as in policy or in terms of research, that you'd love to throw out there and see if it's something that we could grab onto and actually think about designs for that. Molly.
Molly Reisman, the supervisor of Kuehl's office, and Ben gave me a really beautiful opening, so thank you. Because I was going to have a similar caution, which is just I want to be really careful about what we pile on housing case managers, because their jobs are really hard. And I think trying to keep people who are chronically homeless housed is definitely a full-time job, and so we often see studies like this and think, oh, well, we need to train case managers better, and we need to have case managers address, you know, X, Y, and Z when their jobs are oftentimes already so overwhelming that we don't have great retention. So I really want to echo that I think the way to address this is to think about how do we do linkages to the healthcare system so that we can give people better healthcare, better substance abuse treatment, better mental health treatment, but not necessarily that that's the housing provider's responsibility. It may be that our system needs to be designed better to link people to other systems of care and give them the care they need that's responsive to who they are, because that's what we often find is that the healthcare system is not set up to serve people who are chronically homeless well. So it may be that the work really needs to happen in other systems and not necessarily the housing system. The other thing I just wanted to say also is just a caution against how complex what happens in permanent supportive housing is. One of the things that's really disturbing to folks who are site-based permanent supportive housing providers is when you open a new building, you often have many deaths in the first 6 months. And that seems to be, I mean, we have no studies that have looked at this, but our sort of anecdotal hypothesis is that people have a lot of adrenaline that keeps them going on the streets, and that when they get into housing and their adrenaline goes down because their well-being goes up and they can finally relax, their ability to fight their chronic illnesses also goes down, and their chronic illnesses sometimes take over. And you see this in most permanent supportive housing buildings, that in the first 6 months we see a series of deaths, which is really disturbing. I was just doing an oral history with a gentleman this weekend who lives in permanent supportive housing, and he was talking about how his diabetes got much worse in supportive housing because when he was on the streets, he walked all the time. And the exercise kept his diabetes in check, and he went into supportive housing, didn't have to walk everywhere as much, and his diabetes, he gained a lot of weight and diabetes got much worse. So, and it's not that the permanent supportive housing is doing something wrong, it's just people's lives change so dramatically overnight, and they have such complex conditions that, you know, these life changes tend to exacerbate other things. So it's just, I just want to caution us, we sometimes think this work is simpler than it is.
I so much appreciate those points. They are absolutely critical. We need to take them to heart because that is the reality. That is the context in which the results need to be considered. Yes.
Bill Pitkin, Commonwealth Foundation. And you know, on the issue of health outcomes, I think it was, you know, while disappointing, maybe not too surprising for those of us who work in this space, because we know there hasn't been a lot of study, and also certainly the standard of RCT. I wonder if you could say, I mean, I think what was somewhat more surprising was the findings on costs, because that's an area where I think a lot of us feel there's been a lot of study, some by people in this room, very persuasive, very, in terms of cost savings, cost avoidance, different terms, and has been very important for kind of rallying public support, public sector partners, the public in general, in terms of, you know, we're paying a lot for people living on the streets, we can do a better job by housing them, and emergency and other costs going down, some may go up, there being more health care. So I wonder if you could say a word about that, some of the findings of the community discussion in terms of the limitations of some of that literature.
So I should mention that the lens through which we examined the cost issue was the lens of cost effectiveness analysis rather than cost aversion or cost avoidance, for example. So all of the literature was reviewed, and we did, in some cases, as Dan raised, find that emergency room reductions resulted in cost savings. That's extremely important, but we were looking for the kinds of measures that are often used in the health literature. Cost effectiveness studies, where you try to examine how much it costs, the net cost for some level of improvement in a particular population for a particular reason. And the measure that's used in the health services literature is a quality adjusted life year. And in the medical literature, that means that, you know, how much does it cost to improve the quality of life of an individual for one extra year. You know, Gary is the economist, I'm a community psychologist, so you need to step in and correct me if I'm characterizing this incorrectly.
Sure,
but I think that's roughly the issue. And when we have those kinds of measures, when they are carefully applied in efforts to understand who might be more likely to benefit from a certain service in permanent supportive housing than another, can help us make decisions, like from a comparative effectiveness perspective, of what will be most helpful for these individuals versus others in permanent supportive housing. And the cost effectiveness approach in looking at quality adjusted life years or the quality in one's life is better than looking at dollars alone, because we're not then tied to a decision about, well, this thing we're doing here costs a lot more than this thing, so let's choose the cheaper one. Rather, we're, in some respects, divorcing the dollars from those decisions and looking at what each dollar buys in terms of improved life quality. So that was the standard that we were trying to use. And we found that there were, in essence, no studies that focused on cost effectiveness, which is a higher standard and really a more ethical standard of measuring the effectiveness of our dollars spent to improve health. So this is not to dismiss the cost study, the cost avoidance studies that have been done, but rather we were looking at this primarily through the lens of cost effectiveness analysis. And there's I think a whole chapter in that report devoted to that very issue. Does that help?
Yeah, and I think I'm certainly not going to correct anything that you said
well,
there.
You should, if
no,
it's not correct.
it is not incorrect, it is correct. But I think I think what's also been said is that if you are looking at that approach and viewing that as a health intervention, PSH as a health intervention, then you have to follow that kind of approach.
That's correct.
But as we've been talking about today, PSH is not primarily a health intervention, but we also wanted to learn. Did it have the ancillary benefits that at least could be hypothesized going in because of the moves from living on the streets to being housed?
And one thing I want to emphasize again is that it is profoundly clear, and the committee recognized it as profoundly clear, that permanent supportive housing ends homelessness for individuals, and that evidence is firm. But we were called upon as a committee by our supporters, by our funders, to try to answer this question about whether permanent supportive housing changes health outcomes. And so it's an honest question, given that we know how horrible homelessness is for people's health, to then look at, well, since housing is so effective at ending homelessness, could it also impact health outcomes? So that was our specific charge to look at. And, you know, I think committee members were very disappointed that there wasn't more of that strong scientific evidence for permanent supportive housing, that package of housing and services, to be influential in affecting health outcomes. But Ben, Molly, you raised the points about this being a very sick population. So, you know, certainly the physicians on the panel probably weren't too surprised. But now we have an answer. And I still think we should do the very best we can in order to improve people's lives when they are in housing, not to pile on more to already overburdened, hardworking case managers. But this is an argument for more services, the need for more services and support by, at a systemic level, to help us improve the lives of our brothers and sisters, essentially.
So what questions has this conversation brought up in your mind about what you'd want to know in terms of either improving the service mix that exists as it relates to permanent supportive housing or something else? Yes, here in the front. And try to make it brief without comment in this. Yeah.
G. Fania from Veterans Affairs. I was wondering, you know, I know that you've mentioned that there have been a lot of studies that have proven that permanent supportive housing decreases ER visits, but I'm wondering if, even though there's a decrease in ER visits, has that also equaled improved health, even though they're seeing, you know, homeless people are going to the ER less? Are they then engaged in medical services because of permanent supportive housing?
I don't remember that was a finding from studies that we reviewed. It seems reasonable.
So that's a question that we can follow up on and see what's there. Other questions that this discussion has brought up for you? Yes.
Hi, Nicole Fiore from Abt Associates. I'd be really curious if you kind of reran the analysis, say in 5 years. You know, the city and the county have Measure H, you know, Prop Triple H, infused a lot of money, especially under County Strategy B7, to make uniform supportive services under DHS, DMH, and SATC to provide services for people who are new to PSH and existing clients in PSH. So it'd be interesting to see if health outcomes change. If you did the same analysis in 5 years, now that there is kind of a uniformity of supportive services across PSH and Los Angeles.
There's an intent for uniformity.
Mike?
I think it's extremely hopeful.
This side.
Mike Lenz, UCLA. So, this is building off of what Molly said. What this brings to mind is thinking about, if we are asking housing providers, supportive housing providers and case managers to try to fix enormous problems such as people's health care, we also need to be asking healthcare providers and the health services frontline folks to help us identify people that are potentially facing housing precarious situations, potentially chronically homeless. So that synergy should go both ways, right? If we're trying to fix health, if we're trying to fix health through housing, we should also try to fix housing through health. So that's just, you know, one thing that comes to mind.
Excellent point.
There's a question up front here.
So I was wondering, I'm Hannah from State Senator Robert Kurtzberg's office. I just had a question of whether improvements with health would look like some measures like age and HHH, or something more of along the lines of better community partnerships.
I think it's all of the above.
But understanding better what community means,
yeah.
I think is a question that deserves more research. Yes, over here.
Hi, my name is Katie. I'm a Cora Fellow at Supervisor Barber's office. I was wondering, when you talk about enhancement of screening and assessment tools, if within that there's been any critique of the VI-SPDAT itself, or whether that's just sort of considered to be solid and good what it does.
So we actually have written a draft research brief that'll be going up on the HPRI's website, which tries to capture what we know about that, and there certainly has been critique about it as a tool and kind of directions where it can be better going forward. So the answer is yes, but we don't yet know what is the next kind of tool that will improve in those ways.
And VI-SPDAT was part of the package that we looked at.
Of screening.
Yeah.
Mike, question?
I guess it's on track concludes there. Is there any specific recommendations we can make for how we're utilizing our resources through like Measure Age, and is there specific asks we should make our partners in healthcare and health systems that we can start putting into motion now? So like, what are those recommendations, and how can we start having those conversations?
Chris?
What are the kind of health services that residents of supportive housing are most likely to consume? As a basic question. So in terms of even accepting.
And I guess to merge it back to Nicole's question, and how has that changed as we've expanded that population of people being served by PSH?
Ooh, I'm going to add on to that. And who should be, based on Molly's question, who should be providing those services so that it doesn't fall on the homeless service? I mean, I think that's one of the big pieces of this, right? So it doesn't fall on the homeless service provider, right?
Yeah, it's, you were asking before, or making the case for state, local, and foundation funding for kind of additional research. And I was just wondering if on the federal level, either with HUD or HHS, if the team anticipated any interest in funding for, say, a national study, kind of like cross-regional within the United States, that might kind of satisfy some of the research questions.
Well, we certainly made some recommendations regarding what HUD and HHS and CMS should do in partnership. We have no influence. Probably hard to have influence in the federal government at this time, but we hope that this report is taken to heart by officials at HHS and HUD, and that our recommendations are heard there and acted upon.
Well, we're at 10:30, so if you continue to have thoughts and questions and so forth, you can contact HPRI through various mechanisms. If you just want to tweet out a question, you can do that. You can email us, you can call us directly. Because one of the things that we try to do as a community of researchers is to be able to respond with what we know as quickly as we can, provide that information. And then that also, when we talk about what we know, which is what this study has definitively shown, it also leads to all sorts of questions about what we don't know and what we should do to get that knowledge, and how do we approach those kinds of things. One HPRI announcement for those of you who are on the research committee, since this is usually our time when we meet monthly, we were talking with various partners, certainly with Celeste at the city, about this unique opportunity which is going to be rolled out over the next 3 years. El Pueblo being the first example of kind of moving place-based kind of interventions. And for those of us who appreciate research design and so forth, having this timing over, in 15 different council districts for a place-based intervention is a tremendous opportunity to study questions around what happens when you move from unsheltered to sheltered in places that, really is a place where research hasn't spoken in particular. And so I'm going to be reaching out to the research committee to see if you would like to be involved in that. We'll set up in a meeting so that we can understand more of the program parameters that exist between this, and then to talk more carefully about what would need to be done to study this over the next 3 years as we have this really interesting rollout. So that's just a little side note. But getting back to the conversation today, I just invite you again just to really thank Suzanne on behalf of the NAS full committee, but also you coming today to present. And I really appreciate all of your questions and comments and feedback so that we can kind of highlight where our next steps should be in learning more about the kind of the way that PSH affects the lives of those who are housed by it. So again, thank you all.